multiple clinical trials that are evaluating novel therapies for NTM and also for non-CF bronchiectasis. And she's also author of a clinical practice guideline in the Annals of ATS that I thought was really great on use of nucleic acid amplification testing for non-influenza viral pathogens. She is also associate editor for the Journal of Clinical Tuberculosis and Other Mycobacterial Diseases. All of you who know Ashley, both in the training program and also her colleagues, know what an outstanding educator she is. She's also an incredible clinician. She's very active in the American Thoracic Society, serving on the program committee and the planning committee within the Tuberculosis and Mycobacterial Infections Assembly. And she's also formally trained in education. She completed the Yale Education Scholar Fellowship, and amidst all of her many responsibilities, is always an excellent teacher and finds time to both teach, moderate, and speak at meetings around the world. I'm so pleased to introduce her today as she talks about non-tuberculous mycobacterial pulmonary disease. We all know that this is a topic that's really clinically challenging for us as practitioners, but especially for our patients. It's a very difficult disease, and it's exciting to see that Ashley is making progress in terms of developing new therapies and treatment. So without further ado, I welcome Ashley to the podium.
All right, thanks everybody. I'm happy to be able to speak today on NTM lung infections and trying to break this down so that people can see some of the current updates for pulmonary physicians as you are seeing these patients in clinic. So this is the disclosure slides from Yale PCCSM, and if you want to log in for credit, it's up on the board here, but also here, and I think it will go out in the chat as well. And then my disclosure is really just as some advisory board work for several of the industry's companies, and I am a site PI for and sub-I for several of the clinical trials. So to start off, I'm going to begin with a case before we get into the actual topics in today's talk. So this is a patient that you guys might have seen pretty frequently in clinic. A 72-year-old woman. She has a history of breast cancer. She's had a prior mastectomy. Former smoker, light smoking, and presented with about 1 year of chronic cough. She's had several courses of antibiotics throughout this year prior to presentation, and at the time of her initial referral to Winchester, she noted daily productive yellowish whitish mucus, no hemoptysis, and then night sweats that began about 2 months prior to her presentation. No weight loss, but endorsed difficulty gaining weight, and no rashes or joint symptoms. Just briefly, her history is this left breast cancer with a mastectomy, no prior radiation to the chest. She has ulcerative colitis, notably not on any biologic therapy, hypothyroidism, hypertension, and osteoporosis. Really is no known occupational exposures, and then her medications largely just notable for is the tamoxifen and the mesalamine for her ulcerative colitis, and then is denosumab and levothyroxine. So her physical exam, largely unrevealing, which is not uncommon in some of these patients who are presenting to us in clinic, but notably she has a borderline low BMI at 19.9, so she's a thin woman, is well appearing in no acute distress. Her lungs were clear to auscultation, so no wheezes or rhonchi that were present. And then she was a little bit tachycardic and a little bit hypertensive on her vitals as well. Her labs at the time of the initial referral, and this is following our initial lab work as well that came back following that visit, she had a little bit of leukocytosis at 14.6 that had a neutrophilic predominance at about 82%. Her additional bronchiectasis testing that we had sent off, and this was several years ago where this has changed slightly. We had immunoglobulins, so that included our IgG subclasses, IgA and IgM, alpha-1 antitrypsin testing, and a 32-gene CF panel, as if that was negative. She had RAS testing that was within normal limits, and then she had a weekly positive ANA. She did her PFTs at clinic that were with a normal spirometry, normal lung volumes, and then she had a borderline impaired DLCO. So then we had her CT chest imaging that was from the initial referral packet, and I'm just going to show you a couple slices here. So if we can see here on her right side, as we go back up, you can see that she has a little bit more bronchiectatic changes up in that right upper lobe area, and then this kind of nodular opacity where they were reporting it as beginning to have a little bit of cavitation as well. And then she had a little bit of bronchiectasis and tree and bud opacities towards her bases, a little bit on the left as well. And this is just another view. So you can see a little bit more of the left-sided bronchiectatic changes. And again, that right upper lobe nodularity is that was beginning to cavitate based off the radiology reads. So by the end of today's talk, I hope that you will all be able to recognize some of the evolving epidemiologic trends and the risk factors for NTM pulmonary disease. I hope that you're going to be able to apply the ATS and IDSA current criteria for NTM pulmonary disease diagnosis, and then really help you distinguish between what is an NTM colonization versus true infection, and help you decide when is the appropriate time to treat some of these patients. And then lastly, I hope that you'll be able to incorporate some of the adjunct treatment strategies and recognize some of the monitoring that is needed and potentially some of the emerging therapies that are coming down the pipeline as well. So what are NTM or non-tuberculous mycobacteria? These are slow-growing bacteria. So as you will often see that these cultures incubate for generally about 6 to 8 weeks before you get finalized data. And it's like, what are these bacteria? Well, they're made up of a layered cell walls, like with a thin peptidoglycan layer, along with a thick lipid-rich outer layer. And there's many, many different species of these bugs that are identified. It's like well over 200 have been identified, and you will probably see the alphabet soup come back in your culture results. So you are likely well aware that there are many potential species that could grow in any of your patients' lungs. And typically, as like most of these cultures will take about 2 to 3 weeks to subculture, and it will largely depend on the speed of growth, which will further define into rapid growers and slow growers. So typically when we break down AFB species, we have rapid growing mycobacteria, which are typically as if your M. abscessus species. And as if these are over here on the right-hand or left-hand side of the screen here up in the left or in the blue. And then these are typically considered as like opportunistic pathogens. And then it's like we have over here on the right side is like the slow growers. And this is generally where you'll see MAC is like, so Mycobacterium avium, which is a complex. It's made up of many different bugs, but the 3 most common ones are avium, intracellulare, and chimera. And then is like we have the saprophytes, is like, which are down here in the yellow. So these are typically the ones that we consider non-pathogenic species. You can definitely read case reports like where you'll see some of these being more pathogenic, but generally these are ones that we're not as concerned about when we see them isolated in the lungs. And so what is a slow grower? So it's something that takes more than 7 days to culture. And then fast growers, typically you'll start seeing them turn positive on your cultures is like in less than 7 days. And as one of the ways that I like to think about slow growers and fast growers is just trying to relate it over to tuberculosis, where tuberculosis is really more of that infectious cousin that spreads between people quite rapidly, while NTM are more like the quiet neighbors is like from the environment. And is like generally is like they will only cause you problems if you have potentially some host defenses that are down. So why do we care so much about NTM infections? Well, really is if we do see that there's a rising global annual prevalence of NTM pulmonary disease. And this is a relatively recent article that just highlights some of the global prevalence. You can see really down here in Australia or Oceania, Asia, and then also North America, you have higher prevalences reported throughout those regions of the country. And I suspect that even as like amongst these regions and other areas of the world, that this is largely underestimated, given that not every country has the same access to testing. But we're also seeing a lot more trends towards people living longer, more immunocompromised hosts that are out there. Is like that we're now starting to see more of these infections get reported as well. Within the United States, we can see that this trend is also continuing, where we have a rising incidence and prevalence. And this is looking at, on the top here, it's incidence, and then on the bottom here, it's prevalence between 2008 and 2015. So on the left side of the screen here, this is all 2008 data. And then as you move over towards the right, this is the 2015 data. And as you can see, it's getting increasingly darker blue, showing that you're having a rise in your incidence and prevalence throughout the United States as well. And most notably, you can see here is like in Hawaii, is like the rates have always remained relatively high. A relatively recent study that looked at the epidemiologic trends in the US as well as it shows that within the different regions of the country up here on the top left, that you had a rising prevalence as well. Most notably is like in the South, which is the light blue on top, you see that the rates are rising the highest. And then amongst age, we commonly report that those over the age of 65 are those most at risk. But we can see here, particularly in the orange and the light orange, that's most prevalent in those who are over the age of 70. Female gender or female sex is also with the highest incidence. And then with racial distributions, we can see that Asian race is most affected, followed by white populations. And then when we think about comorbidities that are present, this is just two different ways to represent the comorbid conditions. And most notably, as you can imagine, bronchiectasis is perhaps the most common comorbid condition, but we can also see other structural lung diseases, including post-TB lung disease, interstitial lung disease, and airways disease like asthma and COPD, having high comorbid presence as well. Then when we think about the actual species of NTM throughout the United States, there is a specific geographic distribution to the NTM species as well. MAC obviously is the most common, which many of you have noticed in your own cultures that you get higher rates of MAC coming back than other species. And as we can see, mostly in the Northeast and around the Southeast, you have higher proportions of NTM isolates that are identified as MAC, a little bit less in the central parts of the country. But then when we look at different areas of the country as well, including the South area, which is South Atlantic and South Central over here in the middle parts of the graph, you can see that there's also higher rates of M. abscessus. While Mycobacterium avium is our most common species that's identified, abscessus is probably the close second, followed by all of the other species that you might see come back. So oftentimes I get asked by patients, why did I get this infection versus my family member who lives in the same household as me did not get this infection? And there's really a lot of different risk factors that are associated with NTM pulmonary disease. And I think of it first as this triangle here on the left, where you have this complex interplay between the host, the environmental exposures, and then the particular NTM species and its virulence. And that's really kind of highlighted how you need to have all the perfect storm here that comes together to potentially put your patient at risk. And this has morphed over into this depiction of the NTM exposome, which is a little bit more of a complex way to explain it, but it again looks at the host here in the center part of the circle, where you have sex, genetic susceptibility, and age as potential host risk factors. And then you have the environmental exposures. So you have specific environmental exposures, which may include your indoor plumbing, potential risk factors like gardening or showers and jacuzzis. And then you have your external environments that you may not have any control over. So particularly mineral content of the soil has been one of the big areas of NTM research, along with water management systems as potential exposures that patients may have no control over as to whether or not they get exposed. And then you have this whole interplay is again come together to potentially determine whether or not a patient is actually going to be affected by NTM. So when we look at the actual host themselves, taking away all the environmental exposures, we have to think about their own particular risk factors, and not just their age or sex, but particularly within themselves, that they may have acquired or genetic conditions that may increase their risk for NTM infections. So genetic, pretty self-explanatory is when we think about things like cystic fibrosis causing structural lung disease, or potentially immunodeficiencies or alpha-1 antitrypsin as we're screening for potential causes of bronchiectasis. But then we have acquired risk factors as well. And one of the things I think about is in aging populations, or potentially as people who might end up on immunosuppression. That is one of the big ones that might potentially increase their risk for developing these chronic infections. But also things like pneumoconioses and smoking exposure and inhaled corticosteroids and a lot of the treatments that we're doing. And then GERD and chronic aspiration is really one of the close correlates that we do see associated with NTM. So as other potential reasons that they could have some structural lung disease potentially down the line in their lungs as well. And this is a nice depiction from CHEST a couple of years ago, really looking at those who had increased risk of NTM pulmonary disease with comorbid lung conditions. So again, it kind of goes without saying that bronchiectasis and NTM go hand in hand. It's like the peanut butter and jelly of lung disease. But then we have history of tuberculosis. So post-TB lung disease is also one of the risk factors for developing NTM pulmonary disease. And then other structural lung disease like COPD, interstitial lung disease, and airways disease like asthma have increased presence of NTM pulmonary disease. And then interestingly, is one of the findings that they did show is that those who had the presence of pneumonia, and it's hard to say whether or not it was that they had cultures done at that time and had AFB cultures that incidentally found this, or if it was from structural lung disease post-pneumonia that developed this increased risk of NTM, but also solid tumor presence and inhaled corticosteroids as well. And since we're talking about inhaled corticosteroids as a really common medication that we use in the pulmonary practice, it is important to think about how can we potentially de-escalate our patients off of potential inhaled corticosteroids when they're not needed. And really the reason being is apart from the increased risk of respiratory infections at large, we have to think about NTM risk as well. And that's particularly prevalent amongst those who are on moderate to high doses of inhaled corticosteroids. So a lot of times when I'm seeing patients come in, whether or not they were diagnosed with asthma and it was really truly bronchiectasis, or if they do have asthma, I'm also looking at ways to see if I can potentially de-escalate their steroids if possible, depending on the benefit of their symptoms. And then because we're in the age of biologic therapies, it is really important for us to start realizing that there are potential risk factors that are not just TB for increased risk of infection, but also NTM with biologic therapies. Particularly with TNF-alpha inhibitors, we generally think of screening with quantiferin, so we're always monitoring for TB, but the risk factor is not just purely associated with TB, it's also associated with NTM. And this is a nice study that looked at rheumatoid arthritis patients. They looked at the general population here, down on the bottom left. Then they looked at those who were over the age of 50. And then once you saw RA come into the picture for any of these patient populations, you saw that you had an increased risk of NTM and TB, even if they were not on TNF-alpha inhibitors. Then you add in a TNF-alpha inhibitor and both NTM and TB risk factors go up pretty substantially. So it doesn't say that you can't treat somebody or that you can't put somebody on a TNF-alpha inhibitor if they do have an NTM infection, but it does need to make you aware that you might need to have increased monitoring or an increased suspicion for potential development of an NTM infection as well. And then when we look at host susceptible phenotypes, everything's sliding on me. The classic host that we will often remember from medical school studying is really this Lady Windermere, which was Oscar Wilde's story of a lady who frequently did not want to cough and would suppress her cough. So this is a classic phenotype, and many of you have seen patients who might fit this phenotype, where it's an older woman who's typically thin. She might have some pectus deformities, and typically your bronchiectasis is described in the right middle lobe or your lingula, and that's generally a nodular bronchiectatic picture. Conversely, your other phenotype that you might see could be an older male who may or may not be a smoker with COPD, but generally this older male could be thin again, with fibrocavitary imaging. And this is typically thought to be a more rapidly progressive phenotype. So let's go back to my case. So this was, she fit more of the Lady Windermere phenotype. And when she came to see us, she had done all of her bronchiectasis workup, and with her cough and her night sweats, we did get sputum cultures. And she did have a smear positive AFB stain with 4+ Mycobacterium avium complex. At that point in time, we did not have subspecies, which you will now see on most of your culture data currently, within the past 1 to 2 years. But the susceptibility was not yet back at the time of this screenshot. So she came back she actually had a couple of cultures, but how do we diagnose NTM pulmonary disease now that we've seen this patient who's coming in with symptoms? So to obtain a diagnosis of NTM pulmonary disease, you need to kind of meet a trifecta of criteria, and that really involves clinical, radiographic, and microbiologic data. So clinical we'll get into the symptoms, but the microbiologic data is really the big one that you need to have, and that's typically either 2 expectorated sputum cultures or 1 bronchoscopic obtained sample, and that can be either bronchoalveolar lavage or a transbronchial lung biopsy with culture obtained from that and histopathology. So clinical symptoms is like our patient, she presented with cough and night sweats, and there's like really cough is perhaps one of the most common, is like 78% of patients, but you can have a very large list of symptoms that can present. And this is looking at a patient survey, patient online surveys, is like where they showed is it fatigue, productive cough, night sweats, shortness of breath, fever, weight loss, kind of a lot of constitutional symptoms. And then your radiographic findings is that you need to have is like our classically nodular bronchiectatic or fibrocavitary imaging. And these are kind of nice examples of that. But there is some current data looking as well at bronchiolitis, potentially being an early kind of precursor to some of these findings as well. And that's kind of some of the more recent data that's been coming out is like within the past year or so. And then lastly, diagnostics do require this microbiologic standard. And really, as like a culture or traditional culture methods with AFB are really the gold standard in diagnosis. But culture-based assays are fraught with lots of issues. As you all know, they take a really long time to grow. Sometimes they have high false negative rates, whereas you won't get anything, or it's a poor sputum specimen where it just is reported as epithelial cells and saliva, or patients can't get up a sputum. And so there's a lot of work being done right now on potential novel diagnostics as well, looking at nucleic acid amplification tests and serum cell-free DNA, which I think is a pretty neat concept that they're looking at right now. There was a recent study where they looked at serum cell-free DNA for MAC specifically, and this was through the OHSU group. And what they saw is that they could follow the levels for those who were on treatment and potentially use it as a marker or an indicator for treatment response, which is nice to see if you're having that, because how long these cultures take to grow, it might kind of give you an idea if you're having a treatment response at that time. And so these novel diagnostics really do allow for rapid identification. They're highly sensitive and specific, and they may have some of these early utility and treatment monitoring, but obviously lots of work is needed to be done to validate these. And I highlight this figure here of utilizing metagenomics and NTM as kind of how this could really play into everyday clinical practice, because I do think it can really revolutionize NTM diagnostics. I think of it in the way that if you got a sample on a Monday, you might be able to potentially get your DNA isolated, really prep and sequence it throughout the middle part of the week. And then hopefully by Friday, you might actually be able to have results back in your hand that you could help guide the patient as to whether or not they have NTM disease, what is truly there, and what a treatment course might look like. Obviously, this does not show your antibiotic sensitivities, but particularly for patients who are treatment naive, they can where antibiotic sensitivities may not be needed right when you start therapy. This could help really help you inform some of your patient decisions and what might be coming down the line for them in treatment courses. And another question I often get is when is a specimen clinically significant or not? And as I like this figure here, looking at both fibrocavitary and nodular bronchiectatic, looking at some of the bugs over here on the far right, where you see kind of on the red, and typically those who are considered more pathogenic are species like MAC, along with your abscesses, versus on your left-hand side, which are the ones that are considered less likely to be pathogenic, are things like Gordonii or Paragordonii, which are typically more of your saprophytes, where you generally do not see the same amount of clinical disease. And to try to help us distinguish between pathogenic disease versus colonization, there are a couple new screening studies coming out as well that are being developed looking at anti-glycopeptidylipid core IgA antibodies for screening of NTM pulmonary disease. And they show that using, if we're looking over here on the right side of the graph first, this is looking at MAC isolation, those with non-MAC NTM pulmonary disease and those with MAC pulmonary disease. You could see that just having a one-time isolate of MAC versus those with true MAC pulmonary disease, you had higher levels of this IgA. So it does potentially have some clinical implications to help you screen as well for those who might just be colonized versus those who have true clinical disease. So obviously this, again, needs more work to be done, but it might help clinicians potentially distinguish a little bit more readily between those who have clinical disease versus those who are just truly colonized. And another is a way to help determine colonization versus true infection is the use of AI. So there's a couple of different AI methodologies being used, looking at clinical data inputs versus radiologic imaging. And this is through the NTM net. And what they studied their own cohort, and then they used an external validation cohort as well. And they showed that their AI program was able to readily distinguish whether a patient had colonization versus true NTM pulmonary disease as well. So it's like some things coming down the pipeline for clinicians that might be helpful, just given that this is can be a pretty challenging diagnosis, particularly when patients have a difficult time bringing up sputum specimens. And so, as I mentioned already, and at Yale now we have the ability to get some of our subspecies identified in our cultures. And I think about the alphabet soup of NTM and really kind of why is it so important. So if we think about abscessus, which I'm not going to spend a lot of time on today, since it's not the more common of the species, but within abscessus, it is extremely important to be able to try to get that subspecies identification. And really this comes down to ways that we can try to identify this. And for our pulmonary fellows, I know this was recently questions that we reviewed for board studying. And really with abscessus, it's important to identify whether or not the species has a functional gene. And that essentially is something that helps you identify if there's a potential risk for resistance to macrolides, which has very real clinical implications in the treatment success and treatment plans for these patients. So there's two different ways that you can check for resistance within abscessus. You can either have inducible resistance, which requires the cultures to be isolated or incubated for 14 days, or you can check in mutational resistance, which requires a 3 to 5 day incubation. Either way, the big thing that you're looking for is whether or not it is truly there, because that is what ultimately confers whether or not you have macrolide resistance or sensitivity. And that helps you further identify the subspecies of the abscessus. So whether it's abscessus, bolletii, or miscelienses is really what you're trying to get out of this. And what's in a name and why does that matter? So if you can see here, if you're comparing abscessus versus miscelienses, where abscessus subspecies is the one that's resistant versus miscelienses, which is typically not resistant, you can see that the culture conversion rates are relatively abysmal when you have abscessus present. Failure to convert can be up to 60 to 75% in a lot of these patients with subspecies abscessus. So it is extremely challenging to treat. Versus those who are sensitive to macrolides, it's a much more favorable sputum conversion rate of 80s to 90s. So how do we decide when to treat? Are we going to do watchful waiting or initiate treatment? Because we know, as we're going to get into it, these treatments are not easy. So watchful waiting is you might consider in those who have really minimal clinical symptoms, non-cavitary disease, if they were smear negative or a less virulent strain, versus those with the more aggressive findings, that's when you really might kind of consider counseling your patient on starting treatment earlier. And the reason to treat is really because NTM is associated with decreased quality of life, increased mortality, and increased comorbidities. And they did do a relatively recent study in chest looking at watchful waiting, and particularly for patients who had NTM pulmonary disease who were followed over 6 months without starting treatment, they did not see that there was any increased risk of death or understandably no associated culture conversion with that. But this is kind of important as you're talking to your patients, where this is a slowly progressive infection typically. So if they're plugged into a center that can do appropriate watchful monitoring and counseling and adjunct treatments, you might be able to potentially monitor them for a period of time without increased risks of mortality. But when should you really be starting to push your patients to consider treatment? You really do want to identify some of these risk factors for rapid progression. And as I mentioned already, the cavitary disease or smear positive are really some of the big ones. But things like low BMI is associated with progressive disease, obviously comorbid conditions. So immunosuppression is something that we have to be monitoring for. And then male sex and advanced age are also potential risk factors for progression as well. And this is looking at the U.S. bronchiectasis registry, and they saw that of those who were diagnosed with NTM pulmonary disease, generally about 50% of patients will progress over 5 years in time, what does that progression look like? Is it subtle imaging findings, or is it developed cavities or hemoptysis? It's not really entirely clear, but I think it is important as you're counseling patients. And then particularly when we see the figure here on the right, which is looking at patients who had no cavities in the red line, one cavity in the blue, and then multiple cavities on the gray on the bottom, you can see that you have much more rapid progression as like if you have cavitary disease. But when we're looking at NTM versus bronchiectasis within the bronchiectasis registry data, ultimately is like the rate of mortalities do not necessarily increase from just having NTM alone. So I think this is often helpful in counseling your patients that it is a slow growing bacteria, and it is something that we can, if they're in an appropriate setting, you might be able to monitor and counsel them on potential adjunct therapies, and that this may not necessarily be a disease that has to be life limiting. It could be like something that they can live with and potentially be managed as in the outpatient setting. So when we're thinking about treatment regimens and selecting the most appropriate treatment regimens, it really comes down to what the phenotype of the patient is when they're presenting. So is it nodular bronchiectatic, or is it that big cavitary lesion that we're seeing in our patients? And that does help guide what treatments we are selecting. So nodular bronchiectatic is considered the milder phenotype, and you may be able to get away with a 3 times weekly regimen of the 3 drugs, which are typically your macrolide, your rifampicin, and an ethambutol-based regimen. Then is like if you have cavitary disease, generally you should be thinking about adding in as like your IV amikacin at that time point. And typically your IV amikacin is going to be dosed around 3 times weekly, and then generally you're likely going to have a daily regimen on top of that. But abscessus is like, as I mentioned or alluded to already, is like the functional ERM gene really does change your treatment regimen. If you're resistant to macrolide, you're looking at starting generally with a 4-drug regimen from the front. And that's generally going to include 2 active agents, a macrolide for anti-inflammatory purposes, and then IV amikacin. Versus if you had macrolide sensitive, you're likely going to be able to get away with a 3-drug regimen. And that's generally on the first induction period, which is about 2 months of IV therapy before you're looking at transitioning over to a more of a maintenance phase where you might be able to drop one of those agents. And then drug monitoring is so important in these patients. It's like the polypharmacy that's associated with drug-drug interactions, along with the many, many, many side effects that come along with these antibiotics. It's like we're often trying to balance like how do we initiate these medications? Is like, do we potentially look at starting them in a stepwise fashion to help like parse out if patients are having side effects from one versus the other? And then there's like frequent monitoring to really look for cytopenias or LFT abnormalities. Optic neuritis is one of the ethambutol toxicities, so we'll have vision screening. Ototoxicities can occur from both macrolides and your amikacin, so it's like we're looking at audiology assessments as well. And generally, as like in our patients, we'll get baseline labs, and then we're screening labs generally monthly, is like depending on how stable they've been, and then it's like if they've been really stable for a period of time, we'll start spacing them out. And then it's like depending on their baseline hearing assessments is kind of where we're timing how frequent audiology testing is needed. And really, is like I highlight this study is like where is like they followed patients who were initiated on NTM therapy. And it's like the high rate of drop off. It's like where patients ultimately only about 30% of patients are finishing therapy as it compares to those who are initiated on therapy. So these treatments are really not, it's like for the faint of heart. It's like lots of patients do get through it. It's like with monitoring and counseling, but it does highlight that there's often frequent drug pauses, switches, discontinuation, and it's like really trying to make these therapies more tolerable. Trying to educate patients on the adherence and potential ways to help them navigate the side effects, and really just highlighting the need for new drugs to come out as well. So as we get into back to our patient, at her initial visit, she was obviously started on airway clearance, and this was escalated up to getting onto a vest within a couple of months, given the severity of her symptoms. She was started from the initial onset because of that cavitary area with IV amikacin and the 3-drug regimen. But on her repeat CT scan, which was around 4.5 months, she had this enlarging cavity. And then she had persistent smear positive AFB cultures. And I just highlight this that as to be defined as refractory MAC, she was not yet there, but as generally you need to be on therapy for 6 months without culture conversion before you're defined a treatment failure. So this is our patient's follow-up imaging. So you can see there's a really thick-walled new right upper lobe cavitary lesion. And as a kind of really substantially located in the right upper lobe, as the rest of her lobes were pretty spared, which we were thankful to see. But it raised the concern, obviously, as you see an upper lobe lesion, as you need to make sure you're not anchoring on your diagnosis. But as thinking about, could there be something else there? She had a history of breast cancer. So as are we missing something that's potentially not responding to treatment? Since she's been on a pretty aggressive regimen? Or as obviously as right upper lobes, apical and upper lobe cavities, you have to be wondering about other potential species that might be there as well. Thankfully, her prior cultures, all smear positive were negative for TB, but just something to keep in your differential. So she did have her sensitivities, and she had sensitivities before this as well, but she remained macrolide and amikacin sensitive, which we were thankful to see. And this was actually the extended send out from National Jewish. So she was, you can see here you had the rest of your antibiotic sensitivities as well, but her current regimen was still appropriate for her in terms of the actual antibiotic sensitivities. So when we think about why was she not responding to somebody who has an IV agent already on board, along with the 3 drugs that she should be sensitive to, I think it's important to think about what are your rates of culture conversion in nodular bronchiectatic versus cavitary, and then also macrolide sensitive versus macrolide resistant. So macrolide sensitive patients who are nodular bronchiectatic have your highest rates of culture conversion. That makes sense if you're thinking about mild severity of illness, and that's generally, I think this might be an optimistic setting, but 70 to 85% of patients achieving culture conversion. And then cavitary, obviously your rates go down. And then if you have macrolide resistant and you have, your rates go down substantially again. It's quoted anywhere from 5 to 80% that you might get culture conversion, but it's really if you start looking at adding in surgical interventions as well. And then if you think about your patient who had nodular bronchiectatic that you started on 3 times weekly and they're failing to convert, there's actually evidence to suggest that if you go to daily, you might actually gain another 30% of those patients to achieve culture conversion just by switching to daily. So again, going back to that refractory definition, this patient was not refractory, but just for clinical purposes, if you have a patient who's not converting at 6 months, that's typically when you start thinking about treatment failure or refractory patients. And you should be going back and reassessing these patients to check their adherence, potentially checking to see if they've had prior MAC infections that were treated before or developing resistance. Or is there other host factors that might be, causing them to not be able to effectively clear their mucus? So in this case right now, she had a pretty aggressive cavity. So when we're looking at what are the appropriate treatments for refractory MAC, really the guideline approved therapy at this point in time is inhaled liposomal amikacin, or called ALIS. And so this is the nebulized amikacin, which when added to guideline-based therapy, which was your 3-drug regimen, when somebody was determined to be treatment refractory, we saw that there was improved culture conversion rates following 4 months of this being added on to it, so that more patients were able to achieve culture conversion and potentially cure from their NTM pulmonary disease. And ALIS, the formulation is this liposomal formulation, which is thought to really have less systemic exposure and less adverse effects and be more appropriately delivered into the lungs. But really the side effects that we do see relatively common, the percentage of patients being up to 40%. You might get dysphonia, cough, dyspnea. So particularly in patients with reactive airways disease, this is something that you should be monitoring for because it might be hard for them to tolerate. And then this was just a study that followed these patients after they completed their 12 months of therapy from culture conversion. And they saw that those who actually received the inhaled liposomal amikacin were able to had higher rates of sustaining culture converted negative rates of their NTM pulmonary disease compared to those who did not receive it. So going back to my patient, as I mentioned, she had this big cavity. So we referred her to thoracic surgery as we kind of went back to the prior slide, given that her her chances of treatment success were felt to be less likely just given her high burden of disease and smear positive disease still with this appropriate regimen. And so when we think about steps for optimizing NTM pulmonary disease care, I think really treatment success is largely dependent on trying to optimize our adjuncts. So your airway clearance and optimizing the underlying disease, really engaging your multidisciplinary care. I know anybody who manages these patients in clinic, you're probably well aware that they frequently have side effects and may be calling frequently. We rely very heavily on our pharmacy colleagues for education and counseling, and our nursing colleagues as well for education surrounding disease modifications as well. And then looking at their monitoring that's needed as well as just to make sure that they're getting their appropriate screening. So what are some of the non-pharmacologic treatment strategies? Well, it's airway clearance, airway clearance, airway clearance. I feel like a broken record every day in clinic, but it is really one of the biggest things that we can do. Modifying their GERD, making sure that they're staying with a normal BMI, so they're nourished and staying active with exercise, and then obviously quitting smoking. There's also the new NTM and bronchiectasis care center networks, which we are now a site as well. But there's optimizing care through multidisciplinary referral teams. Potentially getting your patient plugged in with a center who's used to dealing with these complex infections and has really the resources to be able to manage these patients appropriately. So that really does come down to having your nursing staff, your respiratory therapist for airway clearance teaching, potentially a social worker to help them deal with their stressors, and then pharmacy and dietitians as well. And really this multidisciplinary care is needed to help reduce the time to diagnosis and help improve patient outcomes, as we can see that the outcomes are quite challenging to achieve appropriate culture conversion. And then surgery it really can be helpful in the appropriate patient population as an effective treatment adjunct for NTM pulmonary disease. And so if in the appropriately selected patients, so generally patients with pretty localized disease, you might have some appropriate benefit from this. And we see that there's low in-hospital mortality rates. The postoperative complications are expected with about 17% of these patients, but really about 93% of these patients can achieve postoperative sputum culture conversion, and they have lower rates of culture conversion or lower rates of recurrence. So only about 9% actually have recurrence. So in our case, this was her post-op. She had a right upper lobe resection. And you can see here on the left-hand side of the screen really is nice removal of that right upper lobe area. She still has a little bit of basilar or more basilar predominant disease. And then her surgical pathology which was one of the big things that we wanted to make sure we weren't missing something else. But that cavity was positive for necrotizing granulomas with acid-fast bacilli. It was PCR negative for MTB. And there was no signs of malignancy, and they also did lymph node biopsies as well on her. And again, there's another screenshot of the scan. You can see obviously there's still presence of bronchiectasis there bilaterally, but the cavity and the burden of the disease is gone. And so what happened to her? So we can see here, I have a timeline here with her MAC smear positive cultures heading up to the time of surgery. And then following surgery, she actually had successful culture conversion almost immediately. So she remained on the 4-drug therapy in the perioperative period, and we did continue the IV therapy post-operatively as well. She did have a complicated course for drug related issues with drug rash. She had some eosinophilia, and she had some decreased hearing acuity as well. About a month or so after the surgery, she transitioned over to inhaled amikacin. And she stayed on that for several months, and then ultimately, due to her side effects from the medications requiring some intermittent pauses, she did actually transition to 3 times weekly therapy, just because the burden of disease was down back to just having nodular bronchiectatic. And then she remained culture negative for MAC for 12 months. Interestingly, at 9 months, she did have paragordonii. We were all very worried for a period of time until that finally speciated, but ultimately not the same bug, and generally is a relatively non-pathogenic organism. So she completed her 12 months of therapy, and she's now been culture negative for 2 years on her intermittent follow-ups. So just highlighting quickly is like the treatment pipeline is there's finally some drugs in development for NTM pulmonary disease. And some of these are refurbished or reused TB medications. As I kept seeing a lot more use of clofazimine recently, which has historically been a TB medication. But also some other treatments that are in the pipeline as well, omadacycline for abscessus. Then we have nitric oxide as some additional implications for IV gallium, and then also as additional indications for inhaled liposomal amikacin, which we'll get into some of the studies that are ongoing now. So for inhaled liposomal amikacin, they are looking at it as a potential first-line therapy for MAC pulmonary disease. And this was the ARISE study, which was released around ATS of this past ATS. And that was really for checking for patient reported outcomes, but they also did have some suggestion of a trend towards culture conversion at 7 months. So in patients who were added ALIS plus azithromycin and ethambutol at the front, in comparison to traditional therapy, they saw that at around month 7, this actually was successful at achieving culture conversion. And now there's an ongoing study from the ENCORE study, which is really looking at true culture conversion rates. Then there's studies looking at potentially substituting clofazimine for rifampin. And what they can see is that if you have clofazimine, ethambutol, and macrolide versus the traditional therapies, that it is relatively non-inferior, and it has pretty comparable side effects when we're thinking about the patients being monitored, and they both show the similar rates of culture conversion at around 6 months of therapy. And this just highlights as well that there's also studies that will hopefully be released in the next year of looking at a 2 versus a 3 drug regimen for MAC as well, which is azithromycin and ethambutol versus the traditional regimen. So hopefully in the coming year, we're going to have some additional input onto whether or not we might be able to get away with additional modifications in our treatments that might make it easier for patients to tolerate. For abscessus, obviously this is a really challenging bug to treat. And this is a case report that was released a couple years ago of a refractory abscessus patient with subspecies abscessus and adding in a dual beta-lactam. And essentially adding in dual beta-lactams might actually be helpful at achieving culture conversion in these patients. And then some of the more novel therapeutics that I like to highlight are inhaled nitric oxide and then an inhaled molgramostim or GM-CSF, and how these, when added to refractory patients on guideline-based therapy, they saw increased rates of culture conversion in these patients as well with safe profiles on the studies, and additional studies are ongoing for those. And then mycobacteriophage. So obviously we do phage here at Yale. Mycobacteriophage is a little bit different. We don't have that one here, but there's a lot of studies going on looking at NTM or refractory NTM infections, particularly abscessus with mycobacteriophage. In Pittsburgh is perhaps the largest center looking at mycobacteriophage, but this is a nice kind of image showing that in a patient who was treated with a lytic cocktail of several mycobacteriophage and in a CF patient with abscessus, that you could actually see that there was a really successful reduction in bacterial burden following phage treatment. And that was, again, kind of reiterated in non-CF patients, with a compassionate use study of 20 cases of refractory abscessus. And they showed that there was potentially positive outcomes and really minimal or no adverse outcomes with the addition of phage. And now there's an ongoing study, particularly in the CF population, called the post-STAMP study, looking at those with refractory abscessus as well. So just to conclude, I wanted to make sure that we highlighted that the incidence is rising, and so is the prevalence amongst the world and in the United States. Hopefully you're able to identify some of these risk factors now when you're looking at your patients in clinic for potentially acquiring NTM pulmonary disease and the risk for progression. Really, the diagnosis is based off the ATS and IDSA criteria, and it really is important to try to get that subspecies identification. And then there's new emerging therapies, but also really focusing in on some of the adjunct therapies and education for these patients is really important for their outcomes. And thank you.
Great.
That was a fantastic talk and really a broad overview of so many important topics. It's exciting to see the progression, and thank you for bringing us up to date. We'll open up the floor now to questions. I think Debbie's monitoring the chat and also in the room. And I'm going to walk up, but as I do, I'm going to ask you one question. The question is, you kind of highlighted the epidemiological kind of wide variance in prevalence around the world. And I assume some of that relates to screening. You kind of highlighted that. Also, maybe some population-based factors. Could you just say a little bit what your sense of it is, seeing patients referred here? I'm sure people have long journeys to reach your clinic. Are there populations that there should be more systematic screening? Obviously, CF is the one we think about, but are others that people are thinking about it, and how might people go about doing that?
So the question was really surrounding is like, how do we appropriately identify patients who might be at risk for having NTM pulmonary disease, and kind of what are the appropriate populations that might be available to screen? And I think the long and the short of that, to Dr. Davis's point, is that there's a lot of delays in treatment, or a lot of delays in treatment and a lot of delays in diagnosis. And as like the availability is like globally for AFB testing is largely like dependent on TB testing, and not always. Oftentimes TB is screened for, and the rest of it is not grown afterwards. And I've seen that as like through some of the ATS collaborations with some of the other as like global chest societies, like where they just don't have the same availability of AFB testing for NTM species, and as like largely, for better or for worse, like it's not a public health, not as large of a public health concern as like from an infectious disease control. But yes, it's like to try to identify as like patients for NTM pulmonary disease. I think the new bronchiectasis guidelines do get to some of that is like in that we should be screening with surveillance cultures, but the frequency of which is really lacking, is it because there's no evidence to say how often should that happen. And I think just trying to increase the awareness of potential symptoms, and for as like us as pulmonary physicians, and as like hopefully primary care as well, for earlier referrals, as like for patients with chronic cough, as like who might be undiagnosed, is like for a long period of time, just because it's not necessarily the highest priority from a mild symptom perspective until it becomes more severe. So I think that's perhaps the population that we should be trying to screen and catch a little bit earlier.
Okay. Sure. Thanks for your wonderful talk. So I was wondering, for patients that have isolated NTM, but they're minimally symptomatic and you've taken the watchful waiting approach, how often are you doing surveillance, and how are you doing surveillance given the high false negative culture rate?
So it's like for patients who have been diagnosed with NTM pulmonary disease with mild symptoms, the question is, how often are we doing surveillance? And so this varies, and you're going to ask many different pulmonary specialists and many different NTM specialists, and everybody's probably going to have a different answer. Dr. Kurtz can probably also support me in that. So typically, if I have a patient who produces sputum, and this is more so just based off of my experience with them, I'll have them drop off cultures several times per year, just as surveillance cultures. And anybody who's covered my inbox before is well aware that I have cultures that are coming back all the time. And a lot of this is really just to highlight is like whether or not a patient is having an increased burden, is like, or more frequent positives. Is like that will kind of help me guide them in my next meeting with them. But it's like in terms of if there's somebody who doesn't produce sputum, then typically I'll have them follow up. It's like if they're mild symptoms, it's like every 6 to 12 months, is like just to check in and make sure they're not developing symptoms.
So Ashley, thank you for such a comprehensive, clear talk. So I want to explore the issue of the diagnostic criteria for a second. And it has a little bit of a flavor of, we say this is NTM disease because this is what we're saying. And so I wonder, to some extent, is it possible that the entire set of patients who have clinically significant illness from NTM could somehow be missed because of strict criteria? So for example, there presumably are a lot of people we call colonized,
yep,
but don't quite have any of the radiographic criteria yet. They continue to cough up NTM. And so the question is, like, what do you do with patients like that? Because we basically say, well, you don't have this illness, even though there's some supportive evidence, but not the criteria. So how do you think about that?
So that's an excellent question. So getting back to those who have symptoms with culture data, but not necessarily radiographic data, I think that's kind of where the new literature is going towards looking at bronchiolitis as a potential early imaging finding for NTM pulmonary disease, and how that might actually be helping you catch patients a little bit earlier on. But as I also think is similar as if you have repeat reads of your CT scans, like you might catch something as like a little bit more subtle as they can follow that over time, that sometimes is like what you think is not there might actually be there and just starting to develop. So I think having that monitoring and close setup for these patients is really important. And hopefully if they truly have no radiographic findings, as again, you start some of the therapies as like that are adjunct and such as the airway clearance and managing their airways disease, you might actually be able to help halt progression towards any radiographic imaging as and potentially keep them kind of in that mild setting.
I guess in that context, I guess what you're saying is that the risk benefit of treating somebody for NTM disease who doesn't have disease presumably is a bad calculation, right? Like, so the risk of side effects and all the hassle and things like that, presumably enough people have decided that it's not worth it.
Yeah, and I think it's like, again, it's like the indications to treat is really based off the diagnostic criteria. And I think is like if you have somebody who has multiple positive cultures, I do think your awareness to monitor as like for potential progression to true radiographic and structural lung disease is needed. But yes, it's like the risk benefit of mild symptoms, mild imaging versus as a potentially starting therapy is for somebody who doesn't have full implications. They are real, and as I think we definitely need to balance that.
Actually, we have a question online, which relates to brensocatib, this new DPP1 inhibitor. I guess the question probably relates to its management in bronchiectasis and specifically in NTM bronchiectasis.
So the question surrounding the new DPP1 inhibitor, brensocatib, if we look at the ASPEN study data, which was released in the summertime in the New England Journal, the patients who were enrolled in that study is like to decrease, is like were ultimately bronchiectasis patients who were not on treatment for NTM pulmonary disease. They could have NTM, but they could not be on active treatment. And so what they saw is that patients with bronchiectasis did have reduced frequency of exacerbations, but specifically the patients with active NTM pulmonary disease needing treatment were excluded from that study.
Maybe more in the future. Okay, maybe one last question up behind. Thank you. Danielle?
Thanks. That was a great talk. If you assume that some of these people have a higher burden of exposure, what do you tell them about exposure reduction? Like, do you tell them to stop gardening, to wear a mask, to clean their shower heads? Like, do you have anything that you advise people in this situation?
Dr. Antner-Zerkis, that is the $1 million question. So the question was surrounding minimizing exposure. So if patients have hobbies like gardening and there's like other potential environmental exposures, like how do we help them manage their risks? And the answer is yes, I do tell them to I try to go through with them as like their environmental exposure. So like as a patient, indoor swimming as frequently as like we look at kind of their exposure to standing pools of water, saunas, hot tubs, shower heads. Like we do go through all of that. And I think it's having that conversation with your patients of what are potential environmental reservoirs for them to acquire this. And then what are potential risk mitigation strategies? So as like I have patients who are avid swimmers, and that is their form of exercise and their aerobic and for their mental health and quality of life. We've had to have some of these discussions of how can we mitigate is like or manage is like the risk of your NTM is like if you're not on treatment or if you got treated and don't want to go back on treatment, how do we navigate this? And if they're not willing to give up, it's like some of these hobbies that are really beneficial for their mental well-being, I think is like having those discussions of what is the risk of reinfection and what can we do is like whether it's augmenting airway clearance, especially surrounding these exposures, to try to help them prevent it. But the long and the short is if they can avoid it, yes, we try to. Is like, but it's like really having those discussions is really important.
Great. So I want to thank the audience for wonderful questions and especially Ashley for amazing. I think we're out of time just because it's 4:02. So I think we probably should move on, but maybe you can come down and ask Ashley, but let's just please join me in a round of applause for a wonderful talk.